So let me introduce Dr. Lael. Dr. Jennifer Lael is a general pediatrician with nearly 40 years of experience in caring for children and youth with chronic and complex conditions with a focus on improving their systems of care. She has practiced in community practice in North Carolina and at Cincinnati Children's Hospital Medical Center, and she currently lives and works in North Carolina. So welcome, Dr. Lael. Thank you so much. I'll turn it over to you to get us started.
Thank you, everyone, and I'm glad you're here. Thank you for joining in with us, and Meg tells me that this is a lively group, so I am counting on you folks who are also subject matter experts to jump in and contribute with us. I do want to say that, particularly with the faculty who are already on the team, we do have some experts in home care, one being Dr. Rishi Agrawal, and there's certainly others who have expertise. And we have a parent with us today, Kara, who I will shamelessly ask to jump in and contribute. So I'd like to begin today because home care supports for kids with medical complexity was something I had to dig into to understand. There's not a lot of data about it. There's not a lot of published literature. And so I just sort of dug into it to figure it out. And two things came just roaring at me. One is the wide amounts of variation, and two are the inequities in the home care supports. So with that said, I'd like to start with a quote from Martin Luther King. And he said, "Injustice anywhere is a threat to justice everywhere. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly." And as I think about our families who are running these many intensive care units at home, I think that Mr. King was absolutely right. So let's go with the next slide, please, Shannon. I'd like to thank the families and the physicians and the nurses who I tapped just very informally and said, "Hey, what are you seeing? What's out there? What's happening?" The first group I worked with, and you see the photographs here, are all HIPAA-consented pictures of real children whose families have said, let us help. So I asked a bunch of families of different family styles. I asked Dr. Noritz from Nationwide Children's and a pulmonologist, Dr. Benscoter at Cincinnati. I asked 3 different complex care docs at Duke, one at UNC, one at Winston-Salem's Wake Forest University, and talked to the complex care nurses who have been on the very front lines at the Complex Care Center at Cincinnati Children's. So I thank all those people for their insights on this. Next slide, please, Shannon. I don't have anything to disclose. Next slide. Now, most of you have seen this. This is Chrissy Lynn's care map of her son Gabe's life. And Gabe this is copyrighted. She's given permission to use it. But Gabe has a lot of complex conditions. And I looked at this, which we've used a lot of times over the years to sort of describe the intricacy of the family's life who cares for a child with medical complexity or a chronic condition. And I didn't have the technological skills to blank out all these different areas as they disappeared when COVID became part of our lives. But if you look at all these different colored domains, we've got education, we've got health, legal, community, recreation, really big hunks of this went away fairly acutely when the schools closed, when offices closed, when the Y closed, when all these things happened, such that what was really left for a lot of these families is just this pale green area of people, family, neighbors, and the support stuff, and sometimes not even that. Next slide, please. Thank you. So I wanted to think about who actually gives home care supports for those who have home and community-based services. And certainly not every child with a chronic condition or with complex condition has home care. We'll talk about that in a second. But what we know is that there are many, many people who contribute to what goes on in the home, which is really a little bit invisible. We don't see that very clearly. The families know exactly what's happening, but the physicians, certainly, we don't get a view in there. So families, siblings, extended families, trusted friends, nurses, non-skilled nurses, non-skilled health aides, teachers, therapists, all these people from the different domains that Mrs. Lind articulated visually all help out in the home care support. We know there are volunteers, we know the faith-based groups help, and we certainly know the equipment and medical suppliers help. That's another area that I think is going to be addressed separately in another ECHO talk. So let's go to the next slide, please. So I didn't know this a number of years ago and had to find out who gets skilled care. How do you say this child has a home nurse or this child has a home aide? And this is merely an example of acuity scales that are used widely across the country. There is no standardized acuity scale. If you just search acuity scales, you're going to get a million of them. But this is the way that a nurse assessor goes into the home and says, I'm going to check boxes and you're going to get points for all of these things you either have or don't have. And then they go ahead, if you would, to the next slide, please. And they add all this up, and you see one side is very technological, the other side is much more non-skilled needs. They add all this up, and look at the bottom. You can see here that depending on how many points you get, it tells you how many hours a week of support you get and who will give it. Now, if you think about that, you say, wow, who does this work? And what we know is that there are health system owned home nursing agencies, there are community nursing agencies, and there are independent providers. And if you go down that ladder, what we know is that the variation across the payment for those groups is incredibly wide. And I will reference you again to Dr. Foster and Agrawal's article that's in the reference list that has actually explicit numbers about the differences in how differently these people are paid. So independent providers notably run their own show. They do not have a lot of oversight. And so on some levels, that works for people. On other levels, it doesn't. The community nursing agencies, of course, have overhead, as do the health systems owned nursing. So the compensation varies differently, as does the pediatric training for this care. So let's go ahead to the next slide, please. Let me remind you that the variation compensation is one thing, but the variation training is another. And if you send a child home with a trach, according to the American Thoracic Society, and that article is in the references, a child with a trach needs an awake, trained caregiver present at all times with 2 family caregivers trained for care. So this is assuming that at every second of every hour of the day that a child has a trained caregiver who is awake and able to tend to them, and that there are 2 people who are trained. So that is a significant thing for the kids who have tracheostomy dependence. So before COVID, we know this was a challenge system anyway. We know there's been a shortage of pediatric trained home care nurses. With the growing population of kids who are tracheostomy or ventilator dependent, especially under the age of 5, we just don't have enough nurses to take care of our children who are on home ventilation. There is instability in the pediatric home nursing, which is multifactorial. There are times when the shifts are uncovered. Someone calls and says, I can't come. The nurses turn over so that you have to retrain people to say, this is what he looks like when he is seizing, those kind of things. And there are call-offs. And there are times when the family says, this is not working for us. This is not a good match, and we need for you to exit. We know that we have a documentation from if you look at Dr. Maynard's article that's in the reference files, of hospital delays with children being discharged because of this nursing shortage. Dr. Nageswaran, whose references are also there, wrote a lot about what levels of problems are we seeing that make this pediatric home nursing unstable, from every level, from the system to the residents to the family to the nurse themselves. There's just many levels where the evolution of communication trust just isn't happening. It does not work. And this contributes to this fractured and inadequate nursing. The compensation is much less than inpatient. If you said, I want to work as an inpatient nurse or a home nurse, the compensation is much less as a home nurse. There is a lot of variation by state. All of you who work with our children with medical complexity know that there are long wait lists for waivers and for long-term care positions. The staff have to go into the residence and work solitarily. It's not like that they have team-based care and can say, hey, come look at this child with me. What do you think about this? They really are working alone. What we know, and the references in the list, is the Commonwealth Fund did some good work looking at who are the aides, the people who are not licensed RNs, LPNs, and they are often women, I think it's 86% are women. Many times they are people of color, and they may have their own issues with low income. So you're already setting up for a situation that is unfair. Next slide, please. So let's switch over from saying we had a system that was a little shaky anyway, and now we're in the COVID pandemic. The variation in home care supports are incredible. I talked to one family who said our nursing is stable, everything's gone just as it was supposed to. And I was astonished. I really didn't know that happened, but apparently it does in systems that are already stable. The unstable nursing falls apart. I had a couple of parents who said, I have no help at all. So many parents are discontinuing their home nursing because of the infectious risk by external caregivers. And they are trying to identify who is good at isolating and taking the COVID issue seriously. One thing that's important for you folks to think about is you may be able to track this, because when a family says, I do not want these people to come to my home anymore, it is documented in nursing orders, which are linked to their CMS 485, the home plan of care. And so if you said, gee, how many of our families discontinued home nursing, that should be able to be picked up in those nursing orders. Many parents are contacting their primary care doc, their specialty care docs, their complex care folks, and saying, I need a letter to support my working from home or for FMLA. And many of them are looking ahead to the upcoming school year and saying, I just can't take the risk of sending my child back to school. And I may not even go back to work. I may just take care of my child. Parents are embracing telehealth avidly, and I've heard 3 different physicians say sometimes we've got to look at them. And telehealth is so charming that people are trying never, ever, ever to go in and be looked at and touched. So we have to think about that as a minor risk. Testing availability and result time is a huge barrier, because if you have a wait time to get a result back, you have all this time when you don't know what you can plan in terms of home nursing support. Certainly, when we look at the injustice and the inequities that are happening, the work disruption, the job loss, the financial stress, families who are essential workers and must expose themselves to the world, that compounds the staffing challenges. Next slide, please. The other inequities that came up as I talked to families, and this really caught me off guard, is what happens in the house. What about the domestic turmoil or crises? I had 3 families mention that there was a discrepancy between what parent A and parent B wanted in terms of the isolation rules. The healthy siblings are trapped as well by whatever rules the family agree to. There's also home crowding. One parent said, I can't have home health aides in here. There's too many people in my house. There was already frail access to mental health supports before COVID, and certainly very little during COVID, and we will hope to work on that afterwards. There is variation across all the nursing policies. If you have a COVID positive family member, some nursing groups will staff that case and some will not. There certainly is wide variation and inequity in the availability of personal protective equipment, both for families and for staffers. And if you have an unstable home or a difficult area of your community, people are less likely to want to go to that area to take that position. Many families have no extra dollars to retain nursing. And certainly, as we know from telehealth issues, that the Wi-Fi availability, the phone minutes, the computer access for any kind of telehealth access is another area of huge inequity. From the families, just to see that these were their words. We are struggling. Burnout is high right now. I wonder how long all of us can keep this up. I feel isolated, scared, and overwhelmed. And I know that when I let my nurse go, I get no guarantee that I will get that nurse back. So those are very heavy, important things. Next slide, please. Some anecdotes. Some families were able to pay nurses and aides not to go to another family's house. One report was of a COVID positive parent and a child who had a tracheostomy was hospitalized for 2.5 weeks on the COVID unit inpatient because there was no nursing. Thankfully, that child is safe. Apparently, nursing coordinators, the ones who supervise people in the homes, are in some places being furloughed, so the supervision is not happening. And there has been reports of non-access to the health systems. You know, so-and-so closed down, I can't get hold of the clinic, I don't know who to call, and parents have said they feel like they're going it alone. It is hard to staff the new cases from home health agency because some people were not taking new cases, and then any child is still in the hospital and trying to be discharged to home, it adds another layer of delay. In one particular case, the staffing was declined for a child who was febrile until her COVID result came back, but it was going to take 7 to 10 days to come back. So it gave the family a week and a half with actually no support. So awful stories. I'm sure you've heard some, and maybe you want to share those. Next slide, please. So let's think about where help comes from. We know that the work that the families have built to say who helps me out is key and critical. We hope that our primary care, specialty care, and complex care centers are contributing. And we know that families are developing CoIIN teams, that is, people they will let in their house who they trust and believe in and know have not been exposed widely. One child told me that his family was creating a tribe of people who take this seriously and recognize the risk to children with chronic and complex disease. One physician reported a really positive telehealth visit by having the home nurse and the patient and the parent and everyone together, and felt very good about that. And certainly we know that our psychological allies and our colleagues are doing a lot of work on psychological support with telehealth. Triage is being done by telehealth, and there's a lot of counseling. Certainly, we cannot ignore the family support groups who have said, I'll take care of this myself, and who have gotten onto social media and said, hey, I got extra gloves, who needs gloves, those kind of things. So help comes from many directions. Next slide, please. So in thinking about how we can help in the health system, I think compassion is the key. When I thought of this family who reported that dads and moms' idea about how restrictive they should be was really creating some tension in the family, I just have to be compassionate about that and say you're all trapped in the house trying to do the right thing for all your kids. This, of course, was along with what Dennis had quoted Dr. Davidson about being flexible, creative, and forgiving. A lot of teams have done communication and outreach using a checklist to say, how's the health of your child? How's your mental health? Who do you have helping you? How's your housing? Is your home safe? And that checklist approach seems like a very good idea to let people know that you care about them and that they do have an ally, that they're not going it alone. When this stuff slows down to some degree, we will need to work on care gap closure and catch up. There are so many things that have gotten put off. I am not going to go in for his eye exam. I'm not going to go in to get his hearing aids adjusted. So we'll have to identify what got missed and help families catch up. I would say that wherever you can, if we can capture data to contribute to research to impact policies, this would be very helpful. If you say our nurses spent 17 hours answering phone calls about XYZ, that would be incredibly helpful information. We do need to work with our families to collaborate and to customize with shared decision making. What do you want to proceed with his scoliosis repair? We know we need to do it. What about his risks? What about things that are semi-elective? I would encourage all the teams to codify your processes for emergency care planning, for telehealth, for your social determinant screening, to say this is how we do it, so that we don't have to make it up again the next time, and we can actually build it into our day-to-day work, not just saying let's make it up as we go. Certainly connecting with your home support suppliers, with the people who are family financial advocates at your hospitals, food banks, all those kind of things. If you start to say, who are my allies? Who, when I am stuck in my house, can I get to help this family? That is very important. And then certainly committing to addressing the inequities that we see in home care delivery. Next, please. Here's your reference list. I really had fun with this, just digging into seeing what's been written and what's not. There's so much more we can learn, and these resources will help you.